Right. And Laura, thanks ever so much for joining us. And I will let you introduce yourself and let you take it away.
Thank you, Jill. So my name's Laura Nisbet. I'm the lead nurse for ADHD at CAMHS. So thank you for joining me today. It's an absolute pleasure to be with you. And I know Jill's been trying to organise this for quite some time. So it's really nice to be with you to talk today a little bit about ADHD in girls. And I'm going to share my PowerPoint with you. So hopefully, if I share my screen, fingers crossed this will work. Can you see my screen okay?
Yes, that's working. Thank you.
Lovely. So if we start from there, I'm just going to... Okay. So we're together today to talk a little bit about ADHD in girls. And Jill very helpfully sent me through some questions to think about while I was putting this together. So I hope I've managed to cover most of them today. And my hope is that by the end of today, we'll have looked at under fives, just very sort of briefly, with ADHD traits in girls. Do girls mask their symptoms? A little bit about puberty, a little bit about the treatment of ADHD, and some just advice for young adults at the end as well. So just as a brief start, I just wanted to sort of set the scene really, just to say, as we all know, that ADHD is a lifelong condition that presents with symptoms of inattention, hyperactivity and impulsivity. And to reach a diagnostic level for that, there needs to be significant impairment in all areas of a young person's daily life that's preventing them from reaching their potential. So under fives. I'm not going to spend too long on under fives because I think we could do a whole talk on that itself, really. So I just wanted to briefly speak a little bit about it. So one of the things I think that always causes the difficulty is how do we know if it's ADHD in under fives? And that can be really hard to tell because all children develop at different rates, they reach the milestones at different rates, and they all have different personalities and temperaments. So it can be really difficult to pull apart what's causing some of those behaviours. But what we would look for really are those levels of inattention and hyperactivity. And it's mainly the hyperactivity and impulsivity I think you see in the young under fives really that are really out with their expected levels for their ages. Now, the NICE guidelines recommend that in under fives, we suggest a parent-focused training programme. So that would be something like the New Forest Parenting Programme or the Incredible Years. And that's not because we think there's anything at all wrong with your parenting or how young people are being managed at home. It's very much around thinking about, from an ADHD perspective, retraining some of those approaches. And the evidence base shows that it really does work. And there's a move towards the parent-led training rather than looking at medication at that age because of the impact that medication has and the side effects that it has on the young person's growth and development. So we tend not to prescribe and we're not licensed to prescribe in under 60. So it's very much around behavioural strategies, and that's why we take that approach. If once those sort of groups have been undertaken by parents and there's still difficulties there, then we might recommend sort of support from early help to do that on a one-to-one basis or intensive support through health visitors. And we provide supervision for those agencies as well, working in that framework, so that all agencies are giving the same approach to the young person. And if there are continued concerns once they reach school age, then at that point we might suggest seeking further advice, really, if all those other things have taken place. Of course, I think there are always the exceptions. There are always the young person who's their child that's really struggling, as I said, normally with the hyperactivity, that impulsivity, the challenging behaviour, sometimes aggressive behaviour. And it may be that those interventions are escalated and CAMHS might become more aware of that young person early and start to work with other agencies and families around how we can best support the child under 5, but they're generally quite extreme cases and dealt with on a one-to-one basis. So I'm just going to move on. Like I said, I don't want to spend too long on under fives. I know you're probably going to have some questions around that, but I do think that's a whole separate area, really. Just thinking about what is on offer across the city at the moment, I know that our commissioners are still in conversations around putting the NFPP in place across the city and other parenting groups that are available, but there are some there that are available through early help and through the health visitors, the likes of EPEC and Incredible Years, so that they are currently out there at the moment.
So Laura, can I just say that we are in the process of just working with early help and some other services across the city to roll out NFPP across, hopefully across Southampton this year, sort of later this year. So Reminds will be doing some groups and other different services well across the city. So we're about to, well, hopefully next month or so, start our training so that we can then deliver that to parents to support them. So
it's brilliant, and I know Kathy's been in discussions with them and the commissioners, so it's kind of in the pipeline, isn't it, rather than, you know,
it's really
concrete. Yeah, so and I think that would be absolutely amazing to have that within our city, because it's currently sort of used across Europe, worldwide, really, isn't it, NFPP? So for us to be finally putting that in place in our city will be amazing, and it really is the evidence base for under fives. So I think that's the message I'd like people to take away, is that we're not in any way saying it's anything about how things are at home or how parents are coping. It's really about rethinking strategies in a different way and understanding where the ADHD comes from. So it's a really positive thing that that's been taken on board and rolling out, Jill. That's brilliant. So moving on, just to think about ADHD traits in girls then. So when we think about ADHD, I think most people have an image, and it's a bit of a stereotype really, of, you know, sort of young boys tearing around, really loud, climbing trees, going a million miles an hour. And what they don't necessarily jump to is a picture of a young girl who might be quite bubbly, friendly, really chatty, but is really struggling to keep up with sort of maybe some of her friendships or her classwork, and that just doesn't get seen. So quite often girls get overlooked and their symptoms get missed, and that means that we quite often will receive referrals for boys more often than we do for girls. So we're twice as likely to diagnose boys than girls with ADHD, but that doesn't mean that it's a condition mainly for boys or that the prevalence is higher. It's just that girls more often get missed. And that's generally due to girls presenting slightly differently, and that girls can be more aware of social expectations in their environment and from others. So they adapt to those, to what's expected, and develop coping symptoms to manage their symptoms more than the boys do. And sometimes what happens is that they start to internalize their symptoms. So rather than acting out and becoming challenging, it all gets pushed down inside them, and their symptoms become more around how they're feeling about themselves and come out in other ways, which we'll go on to look at in a minute. And that means that sometimes parents and teachers are less likely to pick up on the symptoms with girls, and they're less likely to refer for further assessment. Although, like always, there are exceptions to the rule. So we do see girls who do present with that sort of stereotypical ADHD, who can be very busy, who are very impulsive and can be challenging both at home and school. And we also see boys who can present as quite sensitive and quiet and withdrawn, and who are equally as struggling. So it's the exception to the rule, but generally girls do present slightly differently. So, and our society stereotypes just do not help that in any way at all. So we quite often hear as clinicians when we're doing assessments, well, yeah, she's really overly sensitive, or, you know, she's really dramatic, but that's just being a girl. Or you get the boy who's full of energy and they say, but that's okay, that's, you know, he's non-stop, but it's a boy, that's what boys do. And actually that doesn't help. at all. So sometimes girls are described as they're quiet, they're the daydreamer in the class, or as I said, they can be quite overly emotional if they're struggling to manage those big feelings. And I think we need to be really aware of those preconditioned stereotypes that we have to gender so that we don't miss important symptoms with young girls with ADHD. And what happens by grouping them into those types of stereotypes, we start to reframe ADHD symptoms as personality rather than traits of the disorder. And that really reinforces to a young girl, this is about me, this isn't a condition I have, and that she then starts to internalize those difficulties even more. So what do we see when, oh, there we go. So why is it important to recognize those symptoms early? So the evidence shows that the longer ADHD goes undiagnosed and unrecognized in young people, so across both sexes, that the greater impact it has on their life as they develop into adolescence and adulthood. So by recognizing their symptoms early and accessing treatment early, we can help to prevent low self-esteem. We can help them to reduce underachievement academically. So if they can access treatment, they can reach their potential. It decreases the risk of developing risky behaviour in adolescence, so such as drug taking, promiscuity, putting themselves in really vulnerable situations. And it decreases the chances of misdiagnosis, which we see often in adolescence. So of mood disorders, depression, anxiety, and as they get older, into adulthood, the possibility of personality disorder labels when actually it's an undiagnosed ADHD. So what are we looking for? So the descriptions we get for inattention might be a daydreamer. So it might be the young girl who's gazing out the window in the class, who's often lost in their own thoughts. It might be forgetful. So maybe someone who's worked really hard completing their homework, and you might see them doing that at home, but then they just forget to take it with them and hand it in. They might have extreme focus on their interests, so really hyper focused on something that they're enjoying, but then becoming really distressed and almost sort of overly upset when they're asked to stop doing it. When they're not finished, they're not at that point where they want to stop. And they're not aware of what's going on around them while they're doing that activity because they love it so much. They're so engrossed in it. You might find that they start doing lots of different activities and projects, but then just abandon them and walk off halfway through, and they're just left, never completed. They might be incredibly disorganized, so messy bedrooms, messy schoolwork, not being able to find it anywhere. And no matter how hard they try to organize, and you see them trying to organize, or you try and help them to organize, they just can't get that in place. But you also might find that they're quite passive. And often the response you'll get from girls with ADHD is, I don't know. Or they'll ask you questions rather than giving you answers to the conversation because they've just not kept up with it at all. And to hide the fact that they've got no idea what you're talking about, they'll start to ask you questions back to try and get back into that conversation with you. In terms of impulsivity, what you might see is the chatterbot, someone who's really bubbly and friendly, who's constantly talking and isn't quite aware when they get that sort of social response of that's enough now, or they're asked to stop, might stop for a few seconds, but then we'll be back on that conversation. Or they might randomly change topic in the middle of the conversation and be quite hard to pin down to what's actually going on. They'll blurt things out, so they'll be interrupting and talking over others within conversations and having little awareness of the impact that that's having. Or they might blurt out words or what they're thinking about a certain situation or person without thinking about the impact of how what that's going to have on that other person as well. Quite often, especially as girls get older and into adolescence, we see more sort of reckless and risk-taking behaviour. And that might start off as little as, or not little, but as simple as running out into roads, just being distracted and not having any road awareness when younger, but to actually starting to put themselves into quite vulnerable positions with others when they're older. Or, as I said earlier, sort of starting to use drugs and alcohol. And sometimes that's about managing how they're feeling and managing their symptoms as well. And quite often in CAMHS, when we're talking to adolescents, of young girls, it's around getting into situations and thinking, how on earth did I get to this point? What got me here? So they're already vulnerable before they realise what's going on for them. They might have difficulty making and maintaining friendships because of their impulsivity. So the way that they're almost over friendly and almost sort of in other people's personal space, and also being quite verbally and sometimes physically aggressive in their responses, and not quite having that social awareness. Or it might be that they've lost track of what's happening, and that irritability around that comes out quite impulsively in aggression towards others, and that can make friendships quite difficult. And they do display strong emotions. So they might be overtly emotional. So the responses that you get in situations, you might think, whoa, that's really extreme to what I was expecting. Or they can be very easily excitable. So they become heightened in situations quite easily as well. And in terms of hyperactivity, we have that stereotypical, as much as I hate it, tomboy approach, where the girl it just prefers to be active and outdoors, and they might be incredibly sporty, and just always on the go in that way. But more often than not, what we see are these sort of smaller continual movements, so they don't get picked up as much. So they might be constantly moving in the chair. Their hands might be constantly moving as they're talking. You might find that they're doodling all the time, or that their foot's going, just restless, just an ongoing movement, and the inability to settle to one thing for very long. And the fidgeting, so they might sort of show you that by just constantly playing with their hair and twiddling. They might be playing with their nails or picking the nails or biting the nails. It's just a constant sort of restlessness that doesn't stop. And in contrast to the boys, which quite often we see are sort of acting out and challenging and can be quite loud, sometimes girls with ADHD are the opposite. They appear more quiet and withdrawn. They're reluctant to draw attention to themselves, so they want to sort of sneak into the background. They'll spend time watching other people and how they're responding in situations and listening to what others are saying, because of a worry that they might blurt something out and say something wrong. So they would then hold to that in. They won't always seek help. So if they're struggling with work at school, they won't always ask for that support. And so sometimes it means that their abilities are underestimated in the classroom. And because of that, they then fall behind. And sometimes young people will invest so much energy in managing that when they're in an environment that they know the expectations are higher or different. Then by the time they get home, they're emotionally and physically exhausted. And because of that, there can be a fallout. So you might find that those ADHD symptoms become more at home. So you've got an almost a rebound effect of letting it all out where it's safer. And you might find that they are more emotional and their responses more irritable, more challenging at home with you, because of having to hold all of that in different environments. So the question we get asked a lot is around, do girls mask their symptoms? And quite often we hear masking more in terms of autism than ADHD. But I think it's important to recognise, as we've sort of talked on there, especially with girls, it's that social awareness and sort of expectations of others around you, and the impact that that has if you're not sort of meeting those norms, for want of a better word, and the emotions that come with that. So the shame and the anxiety that that can create for young girls. So quite often from a young age, girls will develop unconsciously those coping strategies by watching others, how they respond and how they're acting. And they try to act in the way that's expected of them. So as we mentioned before, that then gets internalized, that gets pushed down inside them as they try really hard not to act in the ways that they've recognized that they do, and draw less attention to themselves. And as I said, sometimes that's around hiding sort of feelings of shame or inadequacy. So examples of masking might be things like taking extra time for homework and activities and chores so that they make sure they get it just right. You might see them actually starting to withdraw and just not do tasks that they find difficult or challenging, or avoiding people that they find it hard to be around. You might see that they actually start to create conflict. There are more arguments, there are more challenging behaviours because they're deflecting from the fact that they're struggling in that situation, or that they've not been able to catch what's going on. So you get an angry response rather than being able to say, I don't understand. You might find that they're checking the work that they do to make sure they've done it completely and correctly, and they'll check it over and over again to make sure. They might have routines for the way that they manage their belongings and things. They like them in a particular place. They'll check to make sure they're there because they don't want to lose things. And again, as I mentioned, they might be more quiet. You might find they're more withdrawn because they're concentrating on the environment and what's going on around them so they can modulate their responses and their behaviours. And more often than not, they'll say what's expected around how they're feeling or what they want, because they want to fit in, they want to please, for want of a better word, rather than actually being honest and open about how they're feeling. And that then itself starts to cause difficulties for the young girl as well. So I found this online last night as well, just as an example of masking. So we've talked about some of these, so staying too quiet and being really careful about what you're saying, checking your belongings to make sure you've got everything. Or you might find actually instead of checking their belongings, they take everything with them to make sure. So you get these girls with really heavy school bags with everything inside just in case. Reacting as you want, as they expect, rather than how they're feeling. Developing those perfectionist tendencies, almost like OCD type tendencies, checking, have to get everything right. You'll get lots of I should do this rather than this is what I would like to do. Can't say that. Suppressing their stimming behaviours. So really holding in some of those that restlessness, not hyperactivity, and then the mimicking and copying other people in social situations to make sure they don't stand out. So the impact of masking, it can create a delay in diagnosis, so the symptoms get missed if the young person is holding in all of how they're feeling and their anxiety, their distress around that, then it just doesn't get picked up. They quite often go under the radar. Or what happens is young people present with the wrong diagnosis. We see a lot of girls come in for low mood, anxiety, self-harm, and they become the focus. And actually it's around an unmanaged ADHD that's just never been picked up, and life's just become too hard and too overwhelming for that young girl because of the level of stress that it causes to internalize those difficulties. And as I said, that can lead to unhelpful coping strategies such as self-harming, alcohol and drug use, And also means that other people just have no idea they have ADHD. So when they do come out later on and say, oh, actually, I've got ADHD, sometimes people don't believe them because they think, well, you've got to 15, 16, you've managed fine. How have you suddenly got that now? And actually, they haven't been managing at all. And there's also a delay then in people accessing the correct help and support that they need, especially in schools academically. So ways to help with masking. I think it's helpful for parents and adults in a young person's life to try and pick up on some of those masking behaviours and to gently start to point them out and question them with the young person around what might be going on for them and why they might be behaving in a certain way. But also to educate them about their ADHD. So really to start to learn, what is ADHD? What is it for me? Because it's different for every individual. And how does it impact on my life? And to start to separate out the condition from their personality so that they internalize less and start to recognize this isn't me, this is the ADHD and the things that I can do to manage that. And that will help with their self-esteem. It might be to encourage healthy masking behaviors. So there may be routines that are put in place that actually really do help them manage their ADHD. So if it is around checking your bag at the end of the night to make sure you've got everything you need for the next morning, then that's a good thing. So helping them to build on the behaviors that will support them moving forward, but also about learning to moderate those behaviors. So if they have to check it and then check it 20 times and that prevents them doing anything else in the evening, then actually how do we support them to reduce that down so it's not being taken to extremes? And then obviously to discourage those negative ones. So if the way of masking is never being able to say this is how I'm truly feeling and expressing my emotions, and actually I have to keep everything bottled up inside until it finally explodes, then how do we support young people to express how they're feeling in a safe way and start to provide alternative ways of doing that? So whether it's things like writing down or having a safe place to talk, or ways to manage that stress, so sort of self-care and relaxation, so that they have other ways of managing some of those behaviours. Okay, so I'm going to move on to puberty and ADHD. So this is a little bit of a minefield in terms of some of the information that I found. It did make me laugh. I wondered if there were some males writing the articles on puberty and ADHD. There was lots about PMS. So I think for anyone reaching puberty, there's obviously a flood of hormones. And as we all know, that creates massive changes in behavior and emotions and physical development for adolescents. And it's a really challenging time for them and for everyone else around them to support them through that. What we do know is that with the start of puberty, young girls have higher estrogen and progesterone levels, and that does have an impact on mood and behavior change. So we can expect, as girls go into puberty, to expect these things. For that then brings along with that higher levels of dopamine and serotonin when estrogen is released in the body, but when progesterone comes along, it decreases those. So the dopamine, which we're going to talk about, is our feel-good hormone, and it helps us all to regulate our moods. It helps us to concentrate better. It gives us our reward system, which increases motivation, and it also helps us to regulate our movement. And we know already that young people with ADHD or people with ADHD have an increased amount of neurotransmitters that take dopamine from the brain, so they have less dopamine in the brain. So when you've got a surge of hormones that are impacting on that dopamine, actually puberty is going to have an even bigger impact for young people with ADHD than their counterparts without, which is hard enough. And the same with serotonin. It works hand in hand with dopamine, and our serotonin in the brain is used to help us sort of stay calm. It helps us focus, again, regulate our mood, but it also helps us in how we're learning and how we commit things to memory, all things that we know people with ADHD can struggle with, and that we know already that they have fluctuating levels of serotonin. So what happens is that when puberty kicks in place and young girls start to develop their menstrual cycle, that can have an even bigger impact on how they're coping. And it also can impact on the severity of their ADHD symptoms, depending on where they are within that monthly cycle. So I know it's rubbish, isn't it? But if you think about, if we break it down into sets of 2 weeks, so the first 2 weeks of the cycle, we have higher estrogen hormones within our bodies. So there's an increase in dopamine and serotonin. And what you actually might then see is that they cope better. So they're able to concentrate that little bit better. Their moods are a little bit more stable. They are a bit more motivated to get things done. Actually, you find possibly the medication can be a bit more effective because it also increases dopamine and serotonin in the brain. So those 2 weeks of the month, things might be going relatively quite well. And then unfortunately, what happens in the second 2 weeks is the estrogen drops away. So the dopamine and serotonin goes away with it. And we have an increase in progesterone, which then also takes away dopamine and serotonin. So you might find in those last 2 weeks of the cycle, things become much, much harder to cope with. And the ADHD symptoms can appear more severe. You might find that there are an increase in sort of mood swings, that people become more forgetful. There is what we call that sort of cognitive fog, where it's just not able to think clearly or sort of get anything done. And those symptoms might become much, much more apparent and much severe. And then alongside that, there is a possibility, and it's still quite anecdotal, there's not a lot of research around it, but with the progesterone and the decrease in the dopamine and serotonin, the impact that the hormone can then have on the medication, you might find that actually it looks like the medications aren't working as well at that period of time. So with the onset of puberty, sometimes what we can see is that girls have been kind of bubbling along, doing okay. Under the radar, things haven't been picked up. And all of a sudden, these symptoms are becoming more impairing. And that sort of alongside the impact of, as you think about the point they're at school, where they're sort of going up into secondary school and you've got more demands and more stress, all of a sudden these ADHD symptoms become more apparent. And we see young girls coming in who maybe haven't been picked up before, but actually there are more and more concerns as they get older. So some of the changes that you might see through, and this is the bit that jarred me slightly, through puberty is an increase in irritability. So they'd be feeling more overwhelmed and unable to cope with things. An increased sense of self, so that internalization can become more, where they're becoming more self-conscious, and it can have an impact on their self-esteem as well. And an increase in that internalization, those negative thoughts about their ability to cope and their ability to manage. And if not able to separate out the ADHD from their personality, you know, why can't they do these things? What is it about me that means I can't do this and my friends can? You might see an increase in emotional reactivity, so an even quicker reaction and more extreme reaction to situations, and sort of more anxiety and sort of lower mood swings. Bit of an emotional roller coaster, and more so, I think, for young girls with ADHD than, you know, their peers who don't have. So how can we help? I think for parents, it's around being really aware of their symptoms and the impact that puberty does have on ADHD, and helping them to develop coping strategies around that. And a lot of that is around behaviour strategies around sort of self-care. And at this time, I know I'm going to really struggle. So what can I put in place to help me? And that might be around things like, you know, taking time out, recognizing that this is hard. So making things easier. So planning ahead. If you know, so say if we're thinking about schoolwork, if we know that we've got an assignment that needs to be handed in those last 2 weeks, can we support you to get that done earlier when you are able to think a bit more clearly and you can concentrate better? And can we plan ahead and sort of plan that in to sort of modulate around how your month is really? It's about modulating your own response, so trying to stay calm and not escalating in a sort of tit for tat. If they start shouting and it becomes a bit of an argument, trying to stay calm and boundaried and consistent in your approach with them, and remembering they're really not trying to be difficult. It's a really difficult stage for anyone to go through, but actually it's even harder for them. Validating their experiences and how they're feeling. You don't need to agree with them, you just need to understand that this is hard for them right now and what they're going through. Start to identify what their strengths are and really build on that with them, and just listening without judging or even trying to problem solve for them. Just sort of being there can be really helpful. So they're really just sort of practical behavioral strategies that we can put in place to support as they're moving through puberty. So moving on to treatment for ADHD, the NICE guidelines sort of stipulate, as we've talked about earlier, sort of parenting programs are first and foremost sort of really the main treatment approach, especially for younger sort of children, and then moving forward it's around looking at sort of social and emotional skills training. So that might be thinking about CBT type approaches to think about how a young person thinks, and challenging some of those sort of internal negative sort of cognitions that people have, or thinking about managing some behaviors, or looking at sort of emotional regulation, so supporting them to think about how to manage some of those emotions that they're having. And if they get to a point where they're quite extreme and they're really struggling to manage with them, things like dialectical behavioural therapy and emotional coping skills, which can be accessed through CAMHS. Psychoeducation for schools and other agencies, so really an understanding of ADHD and the symptoms and how to help manage in those settings. Then obviously we have medication, and sometimes medication is needed in order to support a young person to be able to access the treatment options that we've talked about above, depending on how sort of severe their levels of inattention and impulsivity are, and also around focusing on how to build their self-esteem and focusing on strengths. So I know there were a lot of questions around medication. So just really sort of briefly, in terms of medication for ADHD, first line, we always use something called methylphenidate hydrochloride. It's a stimulant. And as I mentioned earlier, it can increase the dopamine levels in the brain and helps with things like attention, sort of reducing down impulsivity and the hyperactivity, and helps with executive functioning sort of symptoms. And if the young person isn't tolerating the methylphenidate, or that's not working for them, then we would often move to a non-stimulant medication called atomoxetine, which works a bit more like an antidepressant. It takes much longer to build up in their system. So I should have said stimulants tend to work on the day you take them. They work very quickly within sort of half an hour, and they have varying depend on the the brands, they have varying sort of durations that they last throughout that day, but once they've worn off, they're sort of gone out of the system. And the non-stimulants tend to take much longer, so weeks, 8 to 12 weeks to build up to actually have a therapeutic effect, and you have to take them every day. If we are looking to support a young person more with their mood and the impact that ADHD has in conjunction with the young person and their family, we've sort of agreed that actually that's the most pressing symptom to be managing it at that point in time, rather than the ADHD. We might look at using an antidepressant to help modulate and sort of regulate their mood. And sometimes with challenging behaviour, we do look at using very small doses of antipsychotics for managing aggression levels. So you might hear or see various different medications that fall into those categories when we're discussing sort of managing ADHD, but that's very different for each individual and depends on the severity and the symptoms that are causing the most difficulties at that point in time. And the one at the very bottom is this, I think one everyone knows, is the melatonin that's used to help manage sleep, because sleep can be one of the main difficulties with ADHD, whether it's around the increase with activity and the brain being incredibly active and not being able to shut down. So getting to sleep can be very difficult, or sometimes with the actual medication managing the ADHD, it can sometimes have a knock-on effect with sleep as well and make it harder to get to sleep. So we often introduce melatonin to help get a sleep pattern back in place and to support the young person to sleep better. So the benefits of medication, really, what the stimulant medication does is it targets the ability to concentrate, so it reduces the inattention, and the knock-on effect with that is it can slow down impulsivity and reduce the hyperactivity for the young person, so they can again concentrate better. And that's all the medication does. The kind of anecdotal side of that is that sometimes, because this is managed more, we see an improvement in the mood regulation, a reduction in irritability, and an improvement in sort of aggression levels, but they're sort of anecdotal to managing the ADHD itself. One of the questions that Jill asked me was there any medication that doesn't cause lack of appetite? And unfortunately, there's not. It's the main side effect of the stimulant medication and the non-stimulant medication is that it can affect appetite, unfortunately. And that then has a knock-on effect on sometimes how young people grow and develop, and is why we're really reluctant to prescribe medication in sort of 5 and unders as well. The main advice I can give around appetite really is to try and really bolster either side of the medication. So make sure they have a really good breakfast, and when the medication wears off in the evening, that the young person's allowed to eat in order to sort of recoup what they've missed throughout the day if it is impacting on their appetite, and to offer sort of frequent snacks if possible during the day if they're able to tolerate that. But it is the main side effect, unfortunately. And it's a bit of a rhyme, there's no rhyme or reason to who it affects and who it doesn't. Sometimes we have young people who are on stimulant medication and it has no effect on their appetite at all. And it's really about how it is sort of, the word's gone, sorry. It's around how it is sort of broken down within the body and how the body reacts to it, really, whether they will or will not have that side effect. It can also have an impact, as I said, on sleep, and sometimes can cause headaches and stomach aches, and they tend to go quite quickly once the body has sort of got used to having medication and can tolerate it. And occasionally we can see irritableness and increased aggression with these medications, and obviously if that was the case, then we would look at sort of stopping them and swapping over. it really is a bit of trial and error with ADHD medication to find the one that works best for each young person, each individual. Okay, so advice for young adults. Now, it was a huge subject, and I wasn't quite sure advice in what way. So I've kind of generalized this a little bit. And it might be that you have some questions we can think about that, but just in terms of adolescence and beyond, I think the main takeaway message really is that as we get older and life gets busier, there are more stresses that are put upon us. There are more challenges to a young person, so such as, you know, dealing with exams, we're navigating relationships, they're trying to find out who they are as well, you know, going to college and uni, learning to drive, buying a house, getting a job. All of these things put more pressure and stress on a person as they get older, and as you continue into adulthood, you have more than, you know, all of these to juggle at the same time. So through that, we then have an increased sort of reliance on our executive functioning skills. So we need to be able to plan, we need to be able to have self-control, how to time management, you know, we need to rely on our memory and our organizational skills much, much more. And, you know, as we go on into adulthood and have children, we're doing that for ourselves as well as and our children and everyone else in the house. So the impact becomes much, much greater. And I think it's really important to recognize that ADHD is a lifelong condition. And although we can learn ways of coping and ways to build our executive functioning skills, and medication helps to manage these as well, if ADHD remains unmanaged or unrecognized, actually all of these things get harder and harder as we get older. So for me, the first thing would be going back to really understanding the ADHD for the young person, the impact it has on them as an individual, and getting that early recognition around their diagnosis, so that they can start to build those coping skills moving forward and really understand themselves, and accessing treatment. So knowing that medication helps, and the way that it helps, and being able to use it in the way that works for them. So whether it's around, you know, taking it on days when I am in college, but having days off if I need to, because I can cope better and there's less pressure and less stress on those days, then that's fine. But finding what works well for them and sticking to that, and accessing other support if they need it along the way. So as we mentioned before, sort of CBT and emotional coping skills. I think it's really important to practice and develop self-care sort of as a young child through to adolescence and on, so that becomes part of their daily routines, and knowing when things get too much, when it's time to take time out, having things that they really enjoy, that they can do to have that time for themselves, that builds their self-esteem, builds their sort of sense of efficacy, and, you know, building on their strengths, so they really get a feel for, this is me and this is what I enjoy, alongside these are the more difficult things that are there for me. And developing sort of techniques such as, you know, writing things down, making lists if that's helpful, using visual reminders, using things like technology apps that can help you to meet the daily tasks that need to be done, so that you remember and they keep you on task. And having some accountability. So sometimes it's helpful to have someone alongside you, so you can tell them, this is my plan, this is what I need to achieve, and who can help keep you on track if that's something that you struggle for yourself. I think it's about planning ahead, as we've talked about earlier, especially if we are thinking about hormones and times of the month, about what might be easier for us, so that we can then split tasks down into more manageable chunks, so that it becomes easier, but also around how we might be feeling, and knowing the impact that certain situations might have on ourselves and our own sort of physical and mental levels, really, so that we don't get exhausted. And it's also about learning to say no, and recognizing when you've reached that level and you need that time out. So thank you. I don't know if I hope that covered everything, Jill, that you were.
That was so interesting. Yes, it did for me, certainly. And you answered all the questions that I got in advance, which was just brilliant. So thank you ever so much for that. I have a couple of questions. Funnily enough, somebody who had to leave has put a question in, and it was similar to sort of the other question that a parent asked me, which was kind of separating ADHD from autism, and how as a parent, should I be going down this route? How the overlap seems huge. With kids who have both, I hadn't realized how many of some of the issues they have were ADHD related. And whether, I don't know, it's really hard. Let me just get this question from the chat, which says, can I ask, for someone who has received an ASD diagnosis but then told to do a referral for ADHD assessment due to indicators, is it necessary to understand which symptoms are due to ASD or the ADHD, as there seems to be significant overlap in some of the things those given in this presentation? Do we treat or handle them differently depending on the cause? How do we know? Which I think is
it's really difficult, and I think as clinicians it's one that we struggle with all the time. As you say, the overlap is huge, and I think what we have to do really is look at it, if we're talking about helping to support and manage, look at it on a symptom-led basis. So if we know that someone is struggling with inattention, what strategies do we put in place to help them build that? So around, going right back to basics around what can they do now, how long can they focus for now, how do we then start to build on that and extend that, and and that might be about building it 1 minute at a time, and then scoping that out, and again that goes back to really basic new force parenting strategies. So I think it can be very difficult to tweeze and pull apart, and it's very much around understanding, is that so thinking about autism, is that inattention caused by, I'm really enjoying what I'm doing and I don't want to do anything else, which I know we described with the hyperfocus with ADHD, or is it the distractibility comes in with, actually I just cannot sit on task? So it's not that I'm focused, this is what I like, and I don't, in that kind of rigid, this is what I enjoy, this is what I do, but actually this is what I like doing, and I'm just caught up in it and I don't want to stop, rather than I'm not able to focus on it because I'm sitting thinking about 20 million things at once, and I'm picking up on everything that's going on in my environment because my brain can't filter. And that's the difference with ADHD, is that their brain isn't able to filter down to the one thing that they need to focus on. So it's, when we're assessing, it's really about pulling out lots of information to try and understand. And sometimes when you've got both, you can't and it just becomes really difficult. So it's about looking at all aspects of ADHD and how we then tick all the boxes in order to give the diagnosis. So it's not just about the inattention, but do they have the criteria to meet in every area on top of the autism? It's very complex.
No,
and there's no I don't think there's one straight answer.
Yeah,
unfortunately.
of course. I've had a few parents sort of commenting and sort of questioning that they've got the autism diagnosis, but actually what you're describing is very much their child. Either do they have the wrong diagnosis, or should they reapply and go through the whole process to get ADHD looked at?
So I wouldn't say they've got the wrong diagnosis at all. I think it comes back to, it's a neurodevelopmental disorder, and I think you can have traits. So you can have a firm diagnosis of one and have traits of the other, but might not clinically meet the diagnosis level. And I think it's really important that we think about that moving forward as well. And it's around, are those, so the concerns that you're thinking about now, are they managed currently as they are, or actually are they at a point where they're causing difficulties? And the young person's not able to sort of meet their potential beyond. Do you see what I mean? So
yeah.
You can have traits And so you might think, well, yeah, that's a little bit like that, but actually you might then come through and we would say, well, but it's not significant enough, and that sounds awful, but actually the difficulties aren't severe enough to then meet a clinical diagnosis. And I think if you took anyone on sort of autism or ADHD or an LD and we sort of mapped it out, they would all overlap. So it's really about how we put those strategies in place to help manage, and then seeing if things improve.
Yeah, and I guess then if they don't, then they
then
can look to come back and have that looked at. That's really helpful. Somebody else has said, how do they get onto these parenting courses? So the NFPP and the Incredible Years, do you know how they can access them?
So the NFPP, it sounds like hopefully through you. Sometimes. So we're working on that. The Incredible Years and things should be able to access through sort of early help and the health visitors, and I think you can self-refer onto those sort of EPEC courses and things as well. So they're not through CAMHS at the moment, they're all sort of through social services and health visiting.
We have information on those. I'm pretty sure everything's on our website on the advice section of accessing it. To access NFPP, do you have to have a diagnosis of ADHD?
So currently through CAMHS, you do. And we do offer an online resource of NFPP called All About ADHD at the moment, and that is post-diagnosis. So I'm presuming what will probably happen with the NFPP for yourself, so it'll be sort of ADHD informed work rather than post-diagnosis work, but the strategies are very much the same. Yes,
that's our hope, is that we can start getting the support and the advice out to parents, you know, whether they have a diagnosis or not. That is brilliant. Right, does anyone else have any other questions? Feel free to sort of put your hand up or unmute if you can't put it into the chat box. But if not, just give that a sec. But Laura, that's been so helpful. I hadn't realized how much more there was to ADHD in girls. You've certainly opened my eyes up, I think, hugely to the differences, and I think this is going to be so helpful for other parents, just understanding so much more. I come from having had a huge battle with my ADHD daughter this morning about medication, and I'm going at it. I'm going to go home with a different mindset of how things need to be done. So just have one come in. Can we be confident in knowing that the process of diagnosis will have looked at all possible diagnoses within that?
So yes, certainly within CAMHS over the past year, we've moved to a neurodevelopmental assessment. So we will look at screening for both autism and ADHD. And if we have concerns about sort of cognitive abilities and learning abilities, we do look at that within the assessment as well. And our colleagues within autism are now screening for ADHD. And if they pick up ADHD symptoms while doing their autism assessment, they will now complete that part of the assessment as well. So we're moving very much more towards a neurodevelopmental assessment rather than ADHD separately from autism and then having to sit on 2 waiting lists. So I would very much hope so, and hope as we move forward that will continue to go down that route.
Yeah, no, absolutely. It's been a really positive change, I think, the new pathway. And absolutely, no, that's brilliant. I don't have any other questions. Just a comment about thank you, you know, from saying thank you so much for helping and helping understand the children, just waiting for medication. Yeah, I think that one of the issues obviously is the wait for medication, but we know that's not something that you're personally responsible for.
We're doing all we can at the moment to try and alleviate that from every angle possible. I will be sending a letter to everyone who's on that waiting list just to update them and just explain to them a bit about what's going on at the moment, because I think that would be helpful. So if there is anyone who's there at the moment who's on the list, we will be in touch. But we are doing everything we can to reduce that down.
Yeah, no, I know how hard you're all working to try and sort things out, and I think that would be great. I think just sort of parents knowing what's going on often is a huge part of the battle. Let me just see. Yes, another thank you. Ray saying that just starting out on our assessment pathway, feel much more empowered as a result of today, which is fantastic. And so do I on a personal level. I do, and Angie's nodding the other side of the office. You know, saying it's been so useful. I've learned so much, and I think, yeah, it's going to be really, really helpful to other parents and actually to other professionals. So thank you, Laura, for spending so much time doing this for us and preparing everything. Let me stop recording now.